Welcome to The Bone, the podcast that goes deeper. Here we cut through the noise and get straight to the core of the issues that matter. From real stories to raw truths, we dive deep into the conversations that shape our world and challenge our thinking. We're not afraid to dig in and get to the marrow of it all. Whether it's life, culture, or business in sports medicine, we're here to break it down raw and real. No filters, no fluff, just to the bone. With your host, Shelby Daly, we're getting to the bone. This is a clinically pressed, approved CEU podcast. Find the quiz to gain credit at clinicallypressed.org/courses. Clinically Pressed Company, making the complicated simple through results that give back. Find out more at clinicallypressed.org. Let's get started.
Welcome back to The Bone. Today we're talking about joint relocations with Dr. Ethan Kreiswirth and Toki Nakawaza. In athletic training, joint dislocations have been kind of a taboo subject, and whether we should be doing them or not. So I wanted to have Toki on, who's created a company that creates joint relocation simulations, and then Dr. Ethan Kreiswirth, who is the master at relocating joints with his company, Black Belt Sports Medicine. So welcome to the podcast. As I mentioned, Dr. Ethan Kreiswirth, he's in Southern California, and he's the owner of Black Belt Sports Medicine, which contracts with different jiu-jitsu events and provides athletic training. Toki's in Texas, and he's the owner of MN Medical, specializing in creating and supplying medical simulation products to improve individual performance and the entire profession of sports medicine. So, Toki, what inspired you to create this joint relocation simulators?
So, I was the rookie one point, and I had actual reduction, and I had to do on my own. And I was glad because there was no doctor on site, and there was like a away game, and that kind of situation forced me to do it. Because if there was a doctor on site, doctor would do it. So I lose my opportunity, but that happened, and it's like they got to something to practice reduction technique. Like a CPR monitoring. It's a medical simulation product. So it got to be something for sports medicine also. Couldn't find it. So one day I was a little tipsy and it's like, you know what, I'm gonna make my own. So that was the start. Yeah. So and then I went to so many places, like Lowe's and Home Depot, and I got like 50 different springs. My product is low tech. And it's just I use wire and spring to recreate the tension. So I got like 50 really different kind of springs. I mean, try so many. So, but I made it. The shoulder model was created 2013, and then 3 years ago elbow model, and then 2 years ago finger model. And I'm working on hip dislocation simulator right now. And after that, I'm going to TMJ and also ankle model with pulse function. So
very cool.
Yeah.
Awesome. That's great. That's a great idea. The subject of what you're doing now, you saw a gap and you utilized and you took advantage of the gap, because I totally agree with you. There is no practice. Practice is on the human.
Exactly.
When you get the chance to actually practice, if you're not fearful of any type of reprisal that may come through litigation. So it's a great opportunity. So I commend you on the product. It's awesome.
Yeah. Basically just there's no, confidence, just fear and hesitation because you never practiced. So I'm trying to reverse that. So, and it's working, the athletic training program, the KD standard study 2020, they have to teach reduction technique all of a sudden, which is like, all right, I have been reducing it for 20 years. Finally, they're catching up.
That's great.
Yeah. So, and, AT program is my target. But now I'm sending to medical schools. Actually, this morning I had the chat with the medical doctors and the doctor medical school in New York, and they asked my advice. And and also I sold to actually the nursing program. Some nursing program student, they're going to the nurse practitioner, and also they're going to decide to go to the ortho clinic. So they purchased my model, which I kind of surprised, but there's no risk here, so why not?
Yeah. Well, Ethan, so with as many joint relocations that we've seen on the mats, when you became certified, did you start relocating right off the bat, or did it take you a while to get comfortable with it?
Yeah, when you invited me to the podcast, I tried to remember my first reduction, and I can't remember. But I do remember this. When I was a student at Cal State Dominguez Hills, we did our rotations with an ortho through the School of Health and through rotations at the health center. And that orthopedic surgeon, this was 91 or 92, so a long time ago, and he said, "Ethan, would you reduce a shoulder if you had an opportunity?" I said, "No way." He said, "Why?" I said, "Because we're not taught to. We don't know how. We're fearful of it. We're told not to." I mean, even I'm lecturing on the shoulder right now in a class I teach in sports med, and even says in bold letters in the PowerPoint, "Do not attempt a reduction or relocation of a joint." And I'm teaching dislocations, which is crazy to me. So I totally agree with Toki right there. Um, I can't remember when, but this orthopedic surgeon, and the only one, basically pushed that, "Ethan, if you have an opportunity, they're going to sit in the ER for 90 minutes to 2 hours, or they're going to be transported. It's going to take forever. So there's compromise, potentially vascular compromise or neurological compromise. Then why wouldn't you attempt?" So he put that in my head early on as a student. So when I did get the opportunity, and I'm sure it was jujitsu that I attempted a shoulder, because shoulders just want to reduce by themselves. There's so much negative capsular pressure that these joints just want to go in. And since we're on the mat, Shelby, so quickly, you're talking 10, 20 seconds. These things, sometimes they just even self-reduce. I mean, a little bit of traction in the most loose pack position, if you know those per joint, they want to go back in. And I call it negative pressure. So as I teach these students, I'm big on that idea. So I'm sure my first opportunity was the shoulder, if not a finger. And then, I got euphoric on that, just like I get euphoric on suturing people. I've pushed athletic training envelopes with the suturing idea. Are we allowed? When are we allowed? Now, Katie standards are allowing us to teach these production techniques, allowing us to teach these suture techniques. When can we actually implement them, right? And that's our biggest issue. Like, if you're going to teach us or allow us to be taught this information, we should be able to implement this information. So people are still scared. As you know, Shelby, we have a lot of students or you have a lot of certifieds, even doctors who come to our events are a little bit hesitant. And we saw at the last Worlds, some doctors they don't have the practical skills yet, even though they're MDs or chiros or high level practitioners, because they just haven't seen them as much. So, So I don't know. I always say, if you feel crepitus, stop. If you don't feel crepitus, you feel a lot of tension, keep going. And that's really my go-to right there.
Well, do we know how doctors in the ER or orthopedics, how do they get their reps on relocating joints, I guess? Does anybody know?
Well, they usually send those, to the football games, high school football games, and hopefully they get to see it, and hopefully they get to practice. But still, it's hit or miss, not 100%.
Mm-hmm.
So yeah, so that's why I was on the social media. When I market my product, you don't need to send the resident to the football game anymore. Just you can teach them in the classroom. Sounds like, what do you mean? It's like,
Yeah.
but
Yeah.
Yeah.
I mean, I would say it is hard to. I think, just like you made a really good example of, the CPR mannequin, right? So doing CPR on the CPR mannequin is a great way to practice. When it's live and you have a human, man, it's a whole nother
yeah,
level.
yes.
But I do think it's a great idea to get your hands on and feel tension. And it's just scaffolding. So we scaffold the next level of getting your hands on something that you actually can apply, and then next level is trying it on a human being, which is we have a lot of psychosocial factors involved in that too, right? So I would say one of the few joints I haven't reduced yet would be a hip. So that'd be a fun practice.
Yeah, hip. I have a hip coming up in hopefully 3 months on the market. So yeah,
That's
I will come up and I will let you play with it.
Okay, cool. Yeah, we have had multiple mandibular dislocations from jujitsu. So I've had my hands on,
Yeah,
um, of course, ankle, toes, patella, shoulder, elbow. I think that
Elbow is the one I see, when I read some articles, and now I think you have more elbow dislocation from jiu-jitsu. I mean, it's jiu-jitsu tournament every weekend. I mean, schools popping out like crazy in San Antonio right now. So,
yeah,
which is good for the trainer or a healthcare provider to practice the actual one, but, you know,
yeah,
Yeah.
yeah. Just your standard food mechanisms. I think they just do just about everything. So
yeah.
that's what we see. But yeah, when you have a screaming patient with screaming fans and everything else, it's definitely a lot of pressure. And we saw one just recently, and Shelby knows this. She was there. We were in Vegas at Master Worlds, and we had one that just would not reduce. It took three of us to reduce it. Three of us.
Elbow?
Elbow.
Is that the one I mixed?
Yeah, I think that was the one where we were all
Okay.
pulling on it, and it
Yeah.
finally
I
went.
mixed
And the doctor's kind
that
of
was a
poking
YouTube
on it.
video, and I mixed it. I put my reduction practice one on
Oh, that's
on
right.
the
Yeah, you're right. That's right. Yeah,
right. Okay.
we had me hanging on it, and I
Yeah.
put fulcrum underneath his that person's elbow, the patient's elbow, um, and then we had an MD pushing direct pressure down on the olecranon posterior dislocation, and then we had two people hanging on the distal forearm.
Yes. Okay.
I mean,
Yeah.
that took everything. So
Yeah.
imagine. So, and here's the thing: is we're trying to reduce. We have people yelling at us over the stands, like "Stop that! Try harder!" Every the medical doctor, right? And then
Yeah.
when we post to, then you see the plethora of people saying, "What are you doing? Great job! This is horrible. You guys are doing wonderful." So you
Yeah.
really have to like take a step back and say,
All right.
"Okay, I open myself up to criticism here. I put it out there. Is that good or is that bad? I don't know. It depends on
Yeah.
who's."
I mean,
Yeah.
same thing. Is just you don't do X-ray and reduce. I work for high school. I don't have X-ray vision. Well, I might have it now, but like you reduce it without X-ray. That's crazy. You should send it to the ER. It's like, no, I will
Sure.
use my educational, knowledge and then do the steps. And then if you like when you say, you don't feel cryptious, and then just
Mhm.
do it. The age I hate, do not like is 13, 14 years old football player come off the field holding the shoulder. Like, oh my god,
Yeah.
you
Yeah.
know. But other than that, I reduce.
I would say too that had my hands on a few number of broken ulnar radius, and when I tried to relocate, I just felt so much crepitus.
Yeah.
Wrists, one was a elbow, and one was a shoulder, and all came back as one was a humerus with a spinal fracture, the other one was a green stick fracture, and the wrist was just a comminuted fracture.
Oh,
So,
you.
but I felt, and that was the difference. That's when I said, "Aha, okay." I am feeling and hearing
Yeah.
crepitus. So hands off right away, splint, refer. And I would
Right.
say too is anytime we try to reduce, and this is for Shelby's viewers, we always want to refer them, make sure everything clears out with their X-ray and they have good proper
Right.
sensory motor and neurological control. So
Yeah. Well,
yeah,
because that's where we see at the jujitsu events is usually they don't have insurance. First off, they're international, so it's making them as comfortable as possible, and then they kind of have to make the decision after that. We give them all the red flags of if your hand starts going numb, if it goes cold. All you can do is educate them at that point, because I mean, even if you send somebody splinted up with a dislocation, who knows if they're going to go to the doctor and get it relocated sometimes.
yeah. And I would say if they're going to a ER or a clinic and they're not triaged because they're LOC times 4 and they're not shocky, then they're going to sit in the ER. They're just going to
Yeah.
Yeah,
sit.
they're
Three,
stable.
4 hours. Yeah, they're gonna stay, and then
Yeah,
finally, then it's time to see. Oh, you have to call the anesthesiologist.
yeah,
And then, okay, then you get the bill a week later. Oh, it's out of network anesthesiologist.
yeah.
Actually, they are on the network on purpose so they can bill whatever they want. That happens all
Yeah.
the time.
Yeah,
You
so
know?
that goes to Shelby's question is, when are we going to say it's okay to try to reduce, right? Within our practice acts. So that's really, really hard. It's a big question, and I don't know the answer, but it's a very big
Mhm.
question. And I think most people now, I would say, athletic trainers who've had a number of years under the belt are probably reducing fingers and shoulders. They may not be reducing mandibles and ankles, maybe patellas, but you know,
Yeah.
the thing about athletic training and the stuff that we do, Taki, is just we have massive volume.
Yeah.
Massive
Yeah.
volume. And then we always say, it's like, I talked to Shelby, I said, we need MDs here. MDs will get more reps at jiu-jitsu tournaments than they will at 12 weeks, 14 weeks of football.
Oh yeah.
They will,
Yeah. Yeah.
so.
So that, I mean, when I see, athletic trainers, high school setting, if they work, they manage to survive 5 years, I would say you'll be fine. You can be alone, you can cover anything, and you'll be fine.
Yeah, yeah,
But some, if you're first year, second year, just they don't have enough reps, so they're not confident.
that's right.
Yeah. So do you guys see any misconceptions out there about the relocations? Obviously, people are scared,
Yeah,
but what are some of the
So
myths out there?
some, when I go to the conference, some say, well, my state does not allow me to do, which that's fine. I get that. But some say, well, my doctor said, because of nerve damage, I'm not doing it. Because you're athletic trainer, we work under the doctor, so we can't do it. I get that. But, nerve damage to me is like, what about it? Okay, shoulder, 11 to 30% axillary nerve damage possible. But if you know it, if they cannot raise their arm, documentation and reduce it. Same thing as elbow. Okay, if you notice there's nerve damage, okay, documentation, use your phone, record a conversation, protect yourself, and reduce it because it needs to be reduced. Sooner reduced, it's easier. Sooner reduced, patients suffer less pain. Sooner reduced, faster recovery. But people they don't see that. Well, I don't, my doctor said I can't do it. It's like, I don't know, So I don't argue with them. Okay, I understand that, but.
Mm-hmm.
Yeah, I don't understand. I mean, I don't know the data as far as neurovascular compromise because that's the biggest red flag is neurovascular compromise. You're going to put them in a worse state than they're already in. But I don't know the data. Like, and I haven't seen any massive data popping up in front of my face saying that this person suffered, lack of motor, lack of feeling, poor blood flow issues related to a reduction done by an athletic trainer. So I don't know the risk, but then again, I don't know the data deep enough. I would say, we have a lot of people out there reducing, in the means the on the field play. We have a lot of people doing, grade 5 manips with little risk, so I don't see a massive risk, but maybe I'm speaking too forward without reading the data.
But at the same time, I get that. When I was, a freshman trainer, I was scared to death to do it because, shoot, what if I get sued? I got no experience. I got nothing to say. I'm scared to death. So after 5 or 6 years, somebody, trying to come after me is like, I told you. I have a conversation with you, said, that you couldn't raise your arm. There's a nerve damage before the reduction. The dislocation caused the damage. And
Mm-hmm.
there's like, oh, so I mean, it's there people, unfortunately, they're trying to come after you because you got money and they trying to, but it's something you can't avoid. It happens.
I think to get to the truth, we need to basically demonstrate, right, that we can reduce, multiple joints an entire year with no major risk, and then we can say, okay, look, here's our numbers, here's our data, and say we can move forward in attempting to reduce if you're in these settings, right? That's what I think that would be the next step.
Yeah. Well, I know like when we have new staff come in and we talk about relocations and if they're comfortable, some people are like, oh yeah, I can do it except for this joint, this joint, this joint.
Right. Exactly.
What are your thoughts around the most difficult joints that people consider? Most likely the hip and, the elbow probably. What are those fears, I guess, that you guys see?
Yeah, personally, I think all joints, like I said before, they all want to reduce, right? Because there's capsular negative pressure. They want to reduce. So
Mm-hmm.
then we have to think about in what position is the joint. So an anterior inferior shoulder dislocation is going to be a lot easier than a posterior dislocation. We don't see it though. It's just not a normal dislocation that we see in jiu-jitsu and wrestling. Maybe a posterior elbow dislocation, maybe again, I don't know the data, but maybe football or car accident.
Football, because the way it changed the block, there used to be you had to put your arm up, and then
Mhm.
if you got a huge body gap, and you just dislocate.
Yeah, that
So
sounds like
now it's this. So it's a little different technique. They changed, so it's a little less. But yeah, one of
yeah,
the things lineman huge body gap, and then just all of a sudden you get pushed down and then posterior dislocation.
yeah. So
That's
again,
how you.
more still fooshes,
Yeah.
following ideas. But I would think again, athletic trainers are on the field or on the mat or on the court. So, we're there within seconds. So the ability to relocate and just apply traction in a loose packed position of any joint, the joint wants to go back in.
Right.
It's not trying to reduce after 90 minutes.
Yeah.
So that's hard. Now we've had, like just this elbow we had, which was a really hard one to reduce. They went into spasm quick, larger muscles, a little harder
He
to
was a
reduce.
big guy.
I don't think he was too big of a guy. I can't really recall.
Okay.
Probably like medium. He wasn't as big as our
Yeah,
big boys.
definitely female joints, less musculature, smaller frames have definitely gone in a lot easier. Just in my anecdotal evidence, but again, straight traction, no crepitus of any joint. Typically, it wants to go back in. Yeah, you just have to hang on. And the way I think about reductions is, I will hang on a joint. So you just get this like reciprocal inhibition. I'll hang on a joint for 2 minutes. I've hung on a joint for 5 minutes before, sweating my ass off. Me and Chris just hanging, one guy stabilizing the scap and me just hanging on a shoulder, like all my body weight for minutes at a time. Like it's not going to go, and finally it goes. So, and then some people you barely touch it and it just reduces, right? So it's like
Right.
a
Right.
so.
Yeah.
Yeah.
Well, and that's where it was interesting after we had posted on Instagram of that elbow relocation, how many people were like, well, that's the wrong position, or, so many critiques. And it's like, well, I mean, in that moment, that's the position that we decided to choose, and flipping them over wasn't going to be necessarily conducive to anything, and moving them around. So I don't know. Everybody thinks they have the right answer, but they're not in that moment.
Yeah.
Totally agree. And that, I started changing. For personally, I started changing it up a little bit with the elbow dislocation, laying him prone and putting the fulcrum underneath the antecubital fossa. That seems to be the best method, in my opinion. But I have, like, we've had a lot of people comment on the position of the shoulder. I go foot in the axilla. People say, "Oh, that's horrible. You're going to cause a brachial plexus injury, some axonal temesis, or whatever." And again, like, we've been doing this for 20 years now.
Yeah.
Nothing. Yeah, but it's nothing coming back at me, at least, So
Yeah. Well, what about the ankle dislocations? How can you talk that through a little bit?
yeah, ankle dislocations are the easiest because they're just, from what I learned from another ortho, basically picking up the great toe will reduce a talar dislocation. Just straight traction of the great toe. Now, typically, I'll go out. We've had so many of those. I'll go out and just do like calcaneal and dorsum of the foot and just cause straight traction. And remember, nothing's really attached to that talus dynamically. There's no tendons attached to it, so nothing's really holding it other than ligamentous structures, but they're not, neurologically engaged at that point. So it seems to go in pretty easy. We've had really good luck with ankle dislocations. They seem to want to go back really quickly.
Yeah.
Yeah.
Toki, have you made a simulator for the ankle yet?
It's coming up. So next. I mean, we are thinking about TMJ next or ankle joint with the pulse function. So if dislocate, pulse missing, so we have to reduce it to get the pulse back on. So.
Oh, that would be cool.
Yeah. So let me ask you this, Toki. Why mandibular dislocations? You think that's a common one?
Well, so this is the thing. I made it because I was tipsy again, and I made it, and then
I'm over there.
and then I got some dentist stock friends, and then take it over there, and they say, yeah, that's interesting. And then I went to the military base. I have a base here, and then the doctor looked at it and said, you don't need to make one. It's like, so what do you mean? How are you going to reduce it? You don't need to reduce it. Use the gagging reflex. So what he said was use the Q-tip, just rub back against your throat. The human body just gag. It's going to reduce it back. Like, wow, really? It's like, whoa. I never try. I don't know. I mean, if you've seen it, please let's try. I mean, let me know. You see it a lot. I haven't seen it yet. So
we'll tell our staff.
Yeah, seriously.
It's a shallow joint, right? It's a very shallow fossa.
Yeah. So I don't know. It might work. Sounds like I don't know.
Wow. We get it because people tuck their chin and they get this choke, right? and they try to block it with their chin, so it just pops it right out. So I go in thumbs in the mandible, which is probably, dangerous because people can clinch down, but I'll glove up, go thumbs on the
Yeah.
molar, and just do straight like anterior jort, distraction and anterior
Yeah.
jort, and I've had luck both times with that.
Do you do face to face?
Yep, face to face.
Okay, so the Japanese technique somehow they go into the patient on the facing up, they go to the head side and put the hands from the top.
And pull up?
Push down, push down and pull. You gotta push in a little bit and down.
Oh, wow, interesting. Yeah.
Yeah.
Both times I went thumbs inside the molars, my fingers like on the back of the angle of the mandible.
Right. Okay.
Pulled forward, and again, I felt it. It literally wants to pull right up.
Right.
Yeah. So
That's
and both
cool.
times, like, I feel so much better. I'm like, gosh, don't range it again, right? Let me just like tape you shut, Yeah.
So with young athletes with their growth plates that aren't fully fused together, what is the youngest that you guys would do a relocation on, I guess? Or does it matter? Because would they still fracture that growth plate in the ER?
Well, like we talked previously, when I put my hands on it, the shoulder one, if I, ask them to rotate out a little bit, they feel, cracking, it's like, out, go to the ER. That's the age 13, the eighth grader football player or freshman football player. That's the age I really do not like because if that really high possibility that's the case. So.
Yeah, I would go back to the same methodology. If you feel crepitus, it's a no-go.
Yeah.
I did have years ago, I had a kids tournament and a girl dislocated her shoulder. I reduced it and it kept on coming out right in front of my eyes.
Wow.
It would stay in. So either she's in some type of spasm with those tissues or the joint capsule's already torn or just stretched out or neurologically just not engaged. But I would reduce her and literally just slip right out. And she was a first-time dislocator. I remember her very well.
Wow.
Yeah, that's the only one I've ever seen like that.
Gotcha.
Yeah.
Well, there's some people that have a condition.
Oh,
What do you call there's some people that have a loose joint condition, some kind of disease. I don't know.
Yeah, people are really Ehlers-Danlos.
Yes.
Yeah.
So, but
I didn't know anything about Ehlers-Danlos back then. I guess that's possible. This is years ago. So, yeah, she could be hypermobile. Could have been.
Yeah. First-time dislocators and chronic dislocators. Do you guys have any feedback on that?
second, third time. It's surgical. I hate to say it, but yeah. Some people, let's say, Old Tiny, he's sublux, which he's the pitcher and he can throw pretty fastball, which means he's got MDI. So I assume he'll be fine. But some people, the same subluxation might be the end of the career. So
Okay, he'll be great. You know why? Well, you know why she'll be great?
why?
Because he's a right-handed pitcher. He's a left-handed batter and a right-handed pitcher.
Right. That's right. Yeah.
But I would say that Shelby, I just sent you that to post on Black Belt, that Muay Thai fighter who reduced with the ring. He went up to the ring rope and put his ring rope underneath there. Great idea, fulcrum, and then he squeezed down and it just relocated.
Yeah.
Obviously, he's a chronic dislocator. Otherwise, he would.
Right. Yeah, I see some guys, they put like some kind of bottle or something and just, I had one of the YouTube video. I have you did the technique. I put my arm underneath and then said, that works too. So.
I used to do it. I did a towel roll. And then I just pushed down on the humerus. But what I didn't like about that, it just applies so much torque to the humerus, pushing down on the elbow with that. I just felt like it was so much torque and a bit more painful. And then I started moving to this more axillary pressure I do. Yeah.
Cool.
Yeah. So for younger athletic trainers, obviously, Toki, you have a simulator, but do you have any other ways to practice relocation?
Well, so that's the thing. Now they have to teach, But all those clinical professors, they graduate from all KD standards, so they don't know, they didn't learn. So they
Yeah.
buy it, and then it's like, well, and then we want to teach, but we don't know how, So it's like, okay, we can do workshop. I do that. So the
Yeah.
strange thing is, if you buy my product, they have to learn how to dislocate the joint on purpose. So
Interesting.
like, yeah, so my elbow model. So you have to dislocate, right? And then you have to reduce. So it's like, So
Show the album model again.
elbow model
Cool. So he's dislocated right now, right?
is dislocated,
Oh,
yeah. So just sit in position, maybe, and then push and pull in,
okay.
yeah,
Okay. And then how do you dislocate him?
and just little turn.
Okay, you
posterior.
rotate him. You rotate him, dislocate.
Yeah.
Okay, cool. Cool.
Yep.
Right. Great product. Great idea. And I love it again because you're answering a question, And the question is, when are we going to have the opportunity? We watch all these videos of other people do it, but you never get our hands on anybody to do it,
Right.
because even if we did, somebody would probably take over. They get scared. I do
Yeah.
that too on my own athletic trainers who we hire. I get worried. I'm like, I got to do it. And I jump in.
I
And
know.
that's mine. Huge fault of mine. But, I love the idea here. Great.
Yeah.
So now I do. That's my main thing is now is a workshop. I don't sell my product anymore. Just got too busy, and there's a company took over my sales part of it. So just I can focus on workshop. So I do nothing but workshop and go places, go conference, and so.
Great idea. Cool. Great idea.
Bom dia. Calling out agile trainers and students passionate about medical coverage for high-risk events. Are you ready to take your skill to the next level? Brazilian Jiu-Jitsu is a fast-growing sport in the West, and we understand the unique challenge fights face on the mat. From extreme competitors to high-stakes tournaments, Dr. K and his teams are dedicated keeping fighters in the game. At Black Belt Sports Medicine, we specialize in providing sports medicine coverage at the Jiu-Jitsu events. It's fast-paced, quick decisions-making environment with evaluation happening in real time. You will gain hands-on experience and exchange your skill in high-pressure situations. Joyous and experience the adrenaline of working at the forefront of combat sports medicine. You will gain valuable hands-on experience and enhance your skill in high-pressure situations. Are you ready to rise the challenge? Connect with us today at the Black Belt Sports Medicine at gmail.com. Black Belt Sports Medicine, where your passion meets action. Obrigado.
Ethan, what's the craziest dislocation that you've seen or had to deal with?
Well, we had years ago at PANS, we had a tibiofemoral dislocation, and that's a rarity. It was a female semifinal fight in Irvine, and her tibia was completely pulled forward, and it was like tinting the skin really, really bad. Her patella was relocated, so it must have been stretching the heck out of the patellar tendon. Obviously, her cruciate ligaments are probably gone. So I had her on her back, hip at 90, knee at 90, and I straddled her lower leg. I squeezed her lower leg, and I pulled it. So I had my hands on her like hamstrings, and I pulled with my body, and I pushed posteriorly, and it went back in. Does that make sense? Yeah. She ranged her knee. I did her just basically sagittal plane ranging. Then I just did kind of like a little meniscal ranging. And she goes, I want to go. I go, there's no way you're going to go. So, but here we go. Opportunity. She went, she played half guard right away, and she stopped right away. So I gave her the opportunity because it wasn't a concussion or neck injury, but her knee.
Right. Oh, shoot.
Yeah.
So that was probably the gnarliest one. The ones that look really, really bad, like patellar dislocations to the crowd, the ankle dislocation with with one of our big fighters we had years ago looked really, really bad. So I think, visually some of these look really, really bad, but they're not hard to relocate or reduce,
Yeah. So legalities. I mean, I know California is a little different, so I'm sure Ethan, you have Dr. Elmo, I guess, who oversees you. But obviously, for legality reasons, having a supervising physician, talk to them about it and talk about the risks. Reviewing pertinent employee related documents when you're looking to relocate, and then written standing orders, and then checking that your malpractice insurance coverage is going to, cover you in these situations.
Mm-hmm.
But any other problems that you guys see with dislocations that people should be aware of?
Scary parents.
Yeah.
True.
Parents are like my biggest fear, and that's why working kids events are really hard for me now. Parents they can just turn on you, and athletes can turn on you too really, really quickly. Athletes either love you or you're the villain, and parents are the same way. They either love you or now you're the villain. So I'm more scared of the parents and them wanting to be litigious than I am about anything else, I think.
Yeah. Anything from you, Toki?
I mean, like I mentioned about protect myself, protect yourself. That's the thing you can do. And even though, like I said, people can come after you. So
Yeah.
I hate to say it, but
Yeah.
Yeah, I think that's everything in athletic training, right? We're either completely loved or we don't get a lot of recognition for all the great things we do with athletes and the tenure that we do with some of these teams. But when you do one thing wrong or they think you did wrong, then it's let's blast you all over social media. Let's blast you to the public. Let's blast you to to the professional standards. So it's really, really hard. But I just think that athletic training should have a little bit more leeway to start some of these things that we see so much, to waste resources and call it paramedics, waste resources in the ER, for some basic medical things that we can do. I mean, it makes a lot of sense to me.
yeah.
Yeah.
But it's like you also say, it's a process now. All the athletic training program, they have to teach you reduction technique, and they start teaching it, and then hopefully they learn, and so when they see the first one, and then they get to do actual reduction instead of, like you say, instead of going to the emergency room and they get reduced right away, and all they have to do is next day get an X-ray, AP lateral, start doing the rehab right away, and they still all 5 weeks out, maybe 2 weeks, you might be able to play end of the senior year. That's a great outcome to me. So hopefully get to that point.
Yeah. Yeah.
Well, and I think even just the traumatic situation, being able to quickly get them out of pain instead of, the one at JJ Con this year, she was sitting on our table for 45 minutes before the ambulance came, and she was in a lot of pain. Like, her partner was about to kick our asses, to be honest.
Yeah.
And then I don't know how long it took her to get to the ER and how long it took to actually get reduced. But yeah, that one was a tough one, and I think we should have probably tried again, but everybody was not giving up, but it just was so difficult, and we spent a lot of time on that one too.
Yeah, you're talking about the girl with the hip.
Oh,
yeah.
the girl with the elbow that we sent.
Oh, yeah. Yeah, and I think, it's patient by patient. When you're getting so much resistance through, verbal and physical information, really hard. It's really, really hard. And, here we are hanging on these elbows, and there's, could be screaming, either here or in the ER, or do they, because of that's so visual for everyone around us because we're not behind a tent,
Yeah.
It's like, okay, when do I stop? And I am going to stop because you visibly and emotionally, don't want this treatment. So now you're going to wait 90 minutes or more to the ER. Yes, you will be anesthetized, but how, to what end did we apply, so much tissue tension that now you're going to have, irresolvable problems for a long time, so it's a hard go between, so I think we try multiple times and try effectively, not just, I tried, like really, really try and then then we got to let it go. And that's
Yeah.
what we go.
Yeah,
And
I mean, I, you
hate
know,
up my table that I didn't get a chance to reduce. It really hurt. Like we're pretty effective just about everybody. So
yeah,
to me, it's like, come on.
Yeah.
yeah. I mean, it's football now these days. They have a tent, just it's everything is covered now these days to protect their, so I
Yeah,
don't know.
right. You're right. Yeah,
That's the difference, huge difference.
no, you're totally right. We haven't done that in athletic training yet, but maybe it's coming. Maybe it's
Yeah.
coming. We do try to for the suturing stuff and for other stuff. Maybe if they have to, degown, maybe we take them. And there's been media tents we've used for that. But as far
Yeah,
as
little pop-up tent, and just you got put the little cover around it,
yeah,
just protect the views and something
yep,
like that.
yep,
Yeah.
yep.
Well, anything else on dislocations that you guys want to give your 2 cents on?
Well, and also it's like he said, it's a judgment call. People say, so you reduce everything. No, I mean, if you don't comfortable, don't do it. There's nothing wrong with that.
Hmm.
And then people say, so you recommend, you encourage people to reduce dislocated joint. I don't. I'm not a doctor, but I have a doctor back me up, so that's why I do it. And
Yeah.
a lot of trainers, they don't do it because they don't have that connection. They don't have the support. So that's why they can't do it. They don't do it.
Yeah, lack of
And so
confidence.
how are you going to build that? So it takes time. And you go to the doctor's office, you have to, ask questions. You have to show what you know, what you don't know. They're trying to build a relationship. They will trust you. I mean, I don't know where you came up and they're not going to know you. They don't trust you. You have to
Yeah.
build,
Mhm.
so.
Yeah.
Yeah. I always try to tell people too. I think I did an EMT certification in my very, very early years of athletic training. I found it so helpful
Oh, yeah.
because there's so much trauma in EMT and the rotations you do either on the rig or in the ER. I think I spent like a week in the ER. I saw so much stuff that I would never see as an athletic trainer. And then it just builds confidence because you're there and you do that, right? Athletic training, some trauma, comes, but it doesn't come sometimes as much as you see like in the ER. So I always advise people, hey, do your EMT rotation. It's a great way to evaluate too. They have a different evaluation system. I think it's really great. So I always try to advise people to do that, new and up and coming students.
Yeah. Well, that's where I always encourage athletic trainers and students to come out for our jiu-jitsu events because you get more reps in 2 days than
Oh, yeah.
an 8-week rotation sometimes.
Yeah.
Well, I was going to run through some facts from a study. So 2021, there was a survey of 772 athletic trainers, and 46.5% received training from their Katie accredited school. Don't know what that training was.
Well, that was the problem, though. They say you have to teach, but they say
Yeah.
they didn't say how. So
No
some
practical
program
portion,
they show
probably.
the YouTube video, we're done. But it was seriously. And some they purchased my model, and then it's like, can you come for workshop? Yeah, I do that. But some's like, no, we showed a YouTube video. That was it.
Yeah.
So
Yeah, 64% were trained by a physician. 90% of those athletic trainers relocated with or without a physician, and 10% had not relocated a dislocation at all. So kind of crazy. I mean, there's this perception that everybody's uncomfortable, but if 90% of athletic trainers are relocating, I think it's not as taboo as we think it is.
Yeah, maybe.
Yeah.
And I'm teaching, what book am I using? I won't quote the book actually, the text, but in bold letters within the shoulder chapter it says, do not attempt to reduce injury. So it's still being taught, at least through textbooks, current textbooks, don't reduce,
Yeah.
but that's good info, Shelby. That's good.
Yeah.
Yeah. So what trends are you guys excited about in athletic training coming up? Toki, I'll let you go first.
Well, the medical simulation is extremely, extremely huge. I when I made this my model, I didn't know anything about it, but this called IMSH. It's huge, huge, and more products coming up, and any field people using simulation, and I think we're gonna have more medical simulation product for athletic training, and also to me, every profession is, I don't know, evolving is the proper word or not, but now we got to teach. You got to do suture. We got to do IV, which I'm not comfortable IV. Be honest with you, but it's you got to do more and more, and so it's going to be interesting. You might be able to, you know, have to carry portable ultrasound machine, and we take it, send it to the doctors, reduce it. It might happen now. We have pretty much now these days. Every AT has AED. We didn't have it. I didn't have it when I started. So, so
Yeah.
technology.
Ethan, what about you?
Yeah, I've been really high on suturing, just because within our job position, we see a lot of lacks, So I think the ability to close a wound via simple suturing is great, or stapling. We save people a lot of time, a lot of money, a lot of stress and frustration. And if we understand wound care, I think we can really advise on good advice and do the job. And if they're teaching it, then we need to start implementing it.
Right.
Yeah.
Exactly.
Yeah.
Definitely. If you guys could foresee the future, where do you see sports medicine in the next 5 to 10 years?
We're gonna see more. I mean, when I started off this profession, there was nothing. I mean, you couldn't. There's nothing, no job for Amazon. I mean, now we have or auto industry that's a safety specialist. So it's going. I mean, hopefully, maybe 10, 15 years, we might see athletic trainer up in the space. Maybe, maybe.
So you're talking as far as job careers, or you're talking?
As a job, yeah.
No.
We just
Yeah. I'm even asking Shelby because I feel like everything's like wearables and data collection. With an Aura ring, a Whoop strap, everything is wearables. Everything is data collection. More data, more data, more data. We don't know what to do with half the data, but we're collecting data. We love to collect data. So where can that data take us? What will AI be for sports medicine in the future? What does that mean for our jobs? I just think everything is tech. Everything's data. I mean, Toki, you're doing tech, right? It's low tech.
it's a low tech. Yeah, you're right.
Well,
Technology,
Not
low tech.
computerized.
You're going to add to this. Soon you'll be able to have some type of wearable accelerometer on there at what joint force, at what speed, at what velocity you're actually reducing. As somebody, maybe somebody buys your product and on it. But tech is everything. So
Yeah, the University of Ohio, they do the kind of research. How much force you need to do, in which direction, how much extra rotation you need. So let's see.
yeah, it can be done with accelerometers and everything that's already in tech today. But we have a lot of tech in helmets, football helmets, because of velocity hits, high velocity hits. So that's where I see sports medicine, and with the adventation of AI, what is that going to do for us?
Right.
Yeah. Well, I'm hoping that with all this scope of practice of the relocations, the sutures, IVs, that we are going to be able to break away from physician oversight. I think we'll be almost as close as PAs. I'm not sure what's going to differentiate us other than school, but I mean, I can see us running our own clinics and having more autonomy with having private clients and being able to provide public health care. Ultimately, that's where I'm kind of seeing it with what they're incorporating.
Yeah, to add on that, I mean, really, just like PT, they have specialties, right? So they have a specialty in orthopedics or specialties and things. Athletic trainers have been trying that. They're trying it with education, but there should be a specialty in emergency medicine or a specialty in, and we are orthopedics, but they tried the orthopedics, but there should be extreme specialties based on the number of years. So if you have 8 years of experience, then you can apply for the specialty and get certified in the specialty. Then you can do these practices. Because I still think, like Toki said, 0 to 5 years, 0 to 3 years, that athletic trainer, I wouldn't, unless they're great, I'd be pretty worried.
Yeah, I won't trust them. It's like I don't trust them.
We know KD programs, right? We both work for KD programs, so how much information these kids need to retain, and to specialize in that's a whole nother level. So you can introduce and they can be a little bit familiar, but to master, the master is going to come with extreme redundancy, which, black belt sports medicine would give them. That's extreme redundancy. You will see more ACLs at a black belt sports medicine event than you will probably like we said in the whole semester of football.
Yeah.
So yeah.
It's there's a Saturday morning clinic in San Antonio. There's one of the sports clinic. They do Saturday morning clinic, and it's packed. To me, that's the best place to learn. And I go there since '93, and I learned so much. But I see a lot of young ones. They don't say, "Oh, we don't have time. We don't need to go." It's like, nah, that's your call. I mean, I want to improve myself, so I mean, as much as I do it, but.
Yeah.
It's hard. Everybody's got a different work ethic. Some people put 40 hours, oh, it's too much. Some people, they put 80, is nothing. So,
Right.
It's hard. But,
Right.
Yeah. Well, that's where I've always wondered about redundancies on the sideline of why do we have an orthopedic doctor? Why don't we have like a neurologist or, a ER doctor who can help with the trauma stuff that really do need more hands? I don't know what an orthopedic sometimes is helping me with when I've already had me check it, the assistant check it, and then the orthopedic's going to check it. I don't know what more information they're going to get at that point. So I don't know.
Yeah. Plus, like first year resident come in, they check in ACL like crazy. It's torn. Just leave him alone.
Yeah.
It's like, I don't know. It's like, I know. Just don't touch it.
But so great about acute medical care and athletic training is we have the luxury of not having that golden period. We're able to check an ACL, PCL, torn patellar tendons right there in front of you, and then there's no guarding. You're going to actually see it. It's like being under anesthesia. You see it right away. Whereas if they wait for Monday's clinic, they're completely guarded, swollen, and
mushy. So you can't feel that. Yeah,
can't feel it. So, I think having the MD there is cool for validation. It's cool for triangulation of the information, which is good, and it's just good to we still have to look at the pecking order, and the MD is still holds the glass of wine over us. So to speak.
Yeah, definitely. Okay, well, I think we hit that on the head. I think we're good with dislocations. Everybody should be doing them, right?
Give it a couple tries.
So, well, thank you so much. Toki, if somebody wanted to get in contact with you, how do they contact you?
Toki at mn-medical.com, my email. They can contact me for workshop requests. If they want to purchase, also they can send me an email, but I will refer to my distributor. So
okay, perfect. Cool. And Ethan, if anybody wanted to get in contact with you, how's the best way?
You can reach me at Black Belt Sports Medicine. Sounds exactly that. One word, Black Belt Sports Medicine @gmail.com. Or you can reach my Instagram at dr.kre. That'll be Dr. Kreiswirth. We also have a Instagram site called at Black Belt Sports Medicine as well, Instagram.
Perfect. Cool. Thank you so much. And this is To the Bone.
Cool. Thank you.
Thank you.
That's it for today's episode of To the Bone. I hope we've sparked some new thoughts, challenged your perspectives, or simply reminded you to dig a little deeper. Remember, life isn't just about what's on the surface. Sometimes you've got to cut deeper and get to the bone of what really matters. To the Bone podcast is a product of Daily LLC. It is hosted and produced by Shelby Daly, ATC, and Randy Daly. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present. For more on the show, visit www.tothebonepodcast.com. If you enjoyed this episode, be sure to subscribe, rate, and leave a review. Get involved in the conversation. You can find us at www.tothebonepodcast.com. Drop us topic suggestions or be a potential guest. We're all about connecting with you, our listeners. Until next time, stay curious, stay grounded, and keep cutting deep.